Heinzerling. I'm a board member with the California Immunization Coalition, and I work with the Los Angeles County Department of Public Health in the Communicable Disease Control and Prevention Division. And we are very glad to have you joining us for today's Education Hour. The Coalition hosts education hours throughout the year on immunization-related topics to help our colleagues stay up to date on important news and information. Today's call will focus on the University of California's new immunization policy for students, and we will have an overview of the requirements, implementation timeline, and exemptions. We're also going to have an opportunity to discuss the required and recommended vaccines for adolescents and young adults and the important role that our providers play in promoting and providing these vaccines. And we're going to start off today with a quick overview of the objectives of today's call, and then we will give you some information about the webinar itself. So on your screen, you should see our webinar objectives, which are to describe the rationale and purpose of the UC immunization policy. We're also planning to address common questions regarding this new policy, including questions regarding the implementation timeline, exemption policy, and requirements. We hope by the end of the call you will understand the role of providers in facilitating the implementation of this policy, and also we will be identifying some resources that you can use to answer questions about vaccines, vaccine safety, and the new policy. So you may have noticed that we have everyone, aside from our presenters, on mute. So there are some options for you to access the webinar today. Hopefully, since you're on the site already, that you have either dialed in using the phone or listening in over your computer speakers. But for those of you who have not yet been able to get the audio access we have on the screen for those folks, the instructions, so folks can listen over their computer speakers. We recommend that you turn up your speakers, make sure that they're not on mute. Folks can also plug in earphones or headset to a computer. And as I mentioned, all lines aside from our presenters will be on mute during the conference. This is so that we can minimize external noise and make sure that everyone can have a good quality audio for the call. But we certainly encourage you to ask questions using the Q&A panel on the WebEx function. And we're going to cover those questions at the end of today's presentations. So for those of you who have not previously submitted questions through this portal, you can submit written questions, as we said, at any time during the call so that you can jot them down when you have them, or you can hold off to the end. You can need to access the Q&A button at the top of the screen. So you see participants chat and Q&A. Access the Q&A button. You will need to have your screen on split screen, which we'll cover next, but you would type your question into the small box at the bottom. You want to address your questions to all panelists and then hit the send button. And then Catherine Martin, our CIC Executive Director, will be moderating our Q&A session using those questions at the end. So as I mentioned, you can access the Q&A panel from the split screen, so the right-hand side of your screen. Make sure you're viewing it that way so that you can type in your questions for the call. So we're going to go ahead and get started. We want to make sure that we leave enough time for you to hear all the wonderful updates we have from our presenters and have time to answer the questions. And we're going to shortly turn over the screen to our presenters and turn over the microphone to our presenters as well. And I'm very pleased to introduce you to our first presenters, who are Dr. Brad Buchman and Dr. Mary Knudtson. Dr. Buchman is Medical Director of Student Health and Counseling at the University of California Office of the President and Medical Director of the Student Health Insurance Plan, which serves 8 campuses in the University of California system. He is a former Associate Clinical Professor of Family Medicine at UC San Diego. Dr. Buchman will be followed by Dr. Knudtson, who is Executive Director of Student Health at the University of California Santa Cruz Health Center in Santa Cruz, California. He's also Professor of Clinical Nursing at UC Irvine. Dr. Knudtson is the co-editor of the ANCC Family Nurse Practitioner Review and Resource Manual. He's also the author or co-author of numerous peer-reviewed articles, textbook chapters, and educational materials. So we're very pleased to have them here with us today. And we're going to have Prabjot turn over the screen to them so that we can view their slides and hear their presentation.
Hi, this is Mary Knudtson. I'm actually going to be doing the first part of the presentation, and we're going to go ahead and start with the background of the slide information. So if you could advance the slide to that, please. If you could advance the slide, that would be great. I'm not able to advance it. There we go. Thank you. Yeah. The Student Health Services has a mission of protecting the health of students on campus and of the general community, and also educating students regarding health threats and what is appropriate preventative care for them. In 2014, as a response to infectious disease outbreaks that happened on some of the UC campuses over the past 10 years, at the Student Health Center Directors meeting, we decided that we should consider doing a system-wide immunization plan. And part of that was, at most of the campuses, we have had outbreaks or incidents of specific vaccine-preventable diseases happen in our students on campus. Many campuses have had mumps, some have had measles, some have had meningitis, some have had varicella, most of us have had pertussis, and a few of us have had cases of active tuberculosis. We also decided it was a good time to consider this because with the Affordable Care Act, coverage for vaccines and preventative care is now covered at 100%. So the cost of the vaccines is no longer a barrier for the students because all students are required to have health insurance as a condition of enrollment. And then lastly, all of the campuses are on the same electronic medical record. And so that was also going to facilitate data gathering for the immunization plan. Next slide, please. So the implementation process actually started when David Barron, who is the medical executive director at UCLA, said he was going to require all the students at UCLA to enter their vaccine history in the electronic medical record. And at that same time, we had meningitis B outbreaks that had happened on several college campuses, and so the Student Health Center directors voted to pursue a system-wide plan that would include not only vaccine history, but require immunizations recommended by the California Department of Public Health. And the reason we did this was we wanted to be able to link the vaccine recommendations with registration so that in the future we'd be able to put holds on students' registration if they didn't get the required vaccines that we wanted them to have. We weren't going to be able to do it for fall of 2014 because we'd missed the deadlines for registration, so we decided to begin our efforts in the fall of 2015. We identified 5 or 6 Student Health Center directors as the Immunization Plan Committee, and we also had the Office of the President, Student Health Center medical director participate in the planning as well. So the process is going to be, we developed a 3-year plan, next slide, and starting in the fall of 2015, the campuses provided information to incoming students regarding immunization and TB screening recommendations with a required acknowledgement of receipt on their admissions checklist. In addition, we implemented non-mandatory student self-entry of the vaccine information into the secure electronic medical record portal. So that's what we did last fall. Next slide. So for the fall of 2016, all campuses have implemented the student self-entry of the vaccine and TB screening information into the electronic medical record portal, and it's actually sent to the student with a link in their admissions checklist. And they are told that it is a requirement for them to complete this prior to initial registration. For the fall of 2016, this is a soft hold, meaning we are actually not going to put holds on their registration for this fall. Next slide. Next fall, in the fall of 2017, we are going to have the full implementation of the plan, and this is going to be the students are required to enter their vaccine history and TB screening information, again, in the electronic medical record, and they're going to have to submit a verifiable vaccine record. And if they don't submit this, then a hold would be placed for failure to comply. Next slide. So the vaccines that we are requiring all students to have are related to what the California Department of Public Health has said are their immunizations and screening recommendations for college students. And so all UC students are required to obtain these vaccines and undergo tuberculosis screening if they're high risk for tuberculosis. So the vaccines that we've required are the measles, mumps, and rubella vaccine, the varicella vaccine, the tetanus, diphtheria, and pertussis vaccine, and then the quadrivalent meningitis vaccine, and then lastly, screening for tuberculosis dependent on whether they have a high-risk indication. So all students are required to complete a questionnaire. They answer yes on one of the high-risk items, then they're required to either do a quantiferon or a PPD or get a chest x-ray if they've had one of those that are positive. Now, those are the ones that are required. We are also recommending all the normal vaccines, but we're not putting any holds for any of the ones that are the recommended vaccines, only the required. And the reason we've picked these are because these are respiratory transmittable diseases where somebody coughs or sneezes, you could actually get this by being in a classroom or a dorm or sharing space with another student. Next slide, please. So the efforts to date, all the campuses have linked the notices regarding the immunization requirements to the admission and registration communications. So we've done a broad communication plan to all incoming students, to all the constituents on campus in terms of units that this could affect. All of the student health centers have updated their websites regarding this. We've worked with our local campus media. We've also gotten some media attention when this policy first came out that was helpful. And then again, we've had meetings with the Office of the President and other campus stakeholders, including the President is aware of this, the Regents, the Executive Vice Chancellor for UC Health. We've spoken with Council and then the campuses. And I'm going to now turn this over to Dr. Buchman.
Okay, so I am briefly going to go over the immunization module and then move on to exemption. So our immunization module within our electronic health record is set up at each campus to receive client-entered data. So patients enter their data into fields that we can report on. In addition, the module has the ability to upload a photo. So they can either scan it on their computer or copier, they can take a picture of it with their iPhone and upload it, but we are trying to, in addition, obtain a photocopy of their immunization records or titers to, at some point in the future, allow us to verify what's been entered. The program is a little tough to use. The student does have to enter all of the data in one sitting. It doesn't allow you to save and return to complete it. If you make a mistake and send it in, it's not recoverable, and they have to call us and we have to unlock it, so it's a little bit difficult to use. It's not hooked up with the immunization registry yet, and again, we're primarily relying on the self-entered data, which could be accurate and could be inaccurate. And then if we can advance the next slide. Okay, exemption request. Can I just get a signal so I can be sure everyone can hear me?
Yes, we've got you.
Okay, wonderful. Okay, so exemption request. We've had an immunization policy group that's been actually meeting for about a year, and this is composed of a number of people, including campus health center executive directors, med directors, and some people on the plan committee, and now we have a separate committee called the Immunization Exemption Policy Committee. Initially, we only were going to consider CDC-listed contraindications, and later, at some point before I arrived, we added also vaccine manufacturers' inserts, contraindications, as an acceptable alternative. Most recently, in the past couple of weeks, we have had an outpouring of public opinion and opposition to listing only those two as acceptable alternatives. And so now we've agreed to, in addition, accept basically a clinician's documentation that vaccination is considered unsafe and medically contraindicated. Next slide. And so In contrast to California legislation for K-12, we've decided to go ahead and allow not only physicians, but nurse practitioners and physician assistants to submit documentation. We are, in our draft policy, which again is currently just a draft, we are using language from a previous legislation in '99 that authorized or required Hep B immunization in the CSU system and permissively in the UC system if UC decided to adopt a policy. And that language is, as I have on the slide here, it has to be a written statement by a physician. Now we've expanded that slightly. It has to be a physical condition or medical circumstances related to the person such that immunization is not considered safe. And in addition, the clinician has to indicate the specific nature and probable duration of the medical condition or circumstance. So we are actually also getting pushback on that, but we've decided to stay with it. The upper three or upper two conditions are very general statements, but we would like clinicians to write the specific nature and probable duration of the condition. Next slide, please. So the process is that if a student's exemption, they are submitting them to the medical director of their campus locally. As long as it meets one of the three criteria I mentioned previously, they are typically going to be approved. If the medical director at the campus finds the information ambiguous or there's not enough information, they will try to call back to the submitting clinician and see if they can verify or gain a little more information in an attempt to approve the exemption. If it does not meet those criteria, then it can be denied at the campus level, and the student will be advised of that. Now, as Mary said, this year we have a soft compliance. We are not implementing any registration holds this year, but next year in the fall of 2017, we hope to implement those. So if a student has a denial that they've requested at the campus level, they have three options. They can either comply with the immunization requirements, get another vaccine, get a titer, whatever they need to do to meet all the requirements. They can submit a request for an appeal, which I'll talk about on the next slide, and that will be forwarded to a central committee. And then the last option we haven't quite talked about, but I guess conceivably there could be an option of them resubmitting their request, going back to their clinician, and trying to get additional information themselves. Next slide. So in the appeals process, we are forming an immunization appeals committee, and we will choose a total of 3 to 5 members from the exemption policy committee or from the campus medical directors, and that will be for each appeal that we receive. Again, the appeals will be submitted to the campus, and they will de-identify those appeals before sending them on to us. At least 3 members need to meet to look at the appeal request. One of those has to be from the campus of origination, and then we'll make a decision on that and relay that decision to the medical director, who then advises the student. During the term that they submit their appeal, we are not going to prevent them from registering and enrolling in classes, but if they submit an appeal and it's denied at that level, then we will block registration holds for the following year. Next slide. Okay, so our next steps in trying to get this implemented. We're in year 2 of year 3. We need to finish up our draft policy and route that through its circuits in the UC system. We need to improve our electronic health record setup at all the campuses so we can consistently obtain this information and make it easy to verify. We have started outreach efforts communication-wise to prospective applicants, but I think we need to do a much better job so that anyone applying to UC knows well in advance that this is now a requirement, and part of the ticket of coming to UC is that you've been immunized. We need to follow up with communication on people who've been admitted so that if they didn't read the initial materials, we say, now that you've been accepted to UC, please note the following that must be done before you arrive. We do have made some efforts to reach out to some specific groups that might be more affected. So students who come from out of state who may not have the same immunization requirements as California may have some deficiencies in their immunizations. And we definitely know that international students, many of them are going to have deficiencies, and some of these vaccines are not even available in their countries. So we've tried to do some advanced proactive outreach efforts to their communities and their leadership in their communities to try and help them be aware of these new requirements and help us get the word out. Of course, we need to continue to partner with CDPH and the Immunization Coalition and others to promote awareness. And then last slide, please. As Mary, I think, mentioned, and I did too, currently we were just receiving all of this information. We're not validating it, so that would be an important next step. It would be wonderful if we could interface with the immunization registry, although I'm not sure how much effort and work would be required. And then lastly, of course, we would welcome any feedback or ideas that anyone on the call today has for us. And that's it for us. Thank you.
Thank you very much, Dr. Buchman and Knudtson. Great presentation. I know that some folks had a chance to attend a presentation at the CIC Summit this past spring, and this is wonderful to get updated information regarding the exemption process and the next steps. And I know a lot of immunization stakeholders in California have been closely watching because, as was mentioned, there have been cases of vaccine-preventable diseases on campuses, which of course impact the students, but also pretty well-known instances too where kids traveled. They obviously are not restricted to the campus, and so potential to spread outside of the campus area too, and folks might remember a student with measles riding BART and potentially exposing large numbers of people. So wonderful to see UC really voluntarily being a leader in this area, and we appreciate you sharing this information with us. As I mentioned, we're taking our questions at the end of the call today, so we're encouraging folks to continue typing their questions in the Q&A. We already have a couple in queue that we can cover when we reach the end of the call. But in the meantime, we're going to move on to our final presenter, who is someone very familiar to many folks on CIC, Dr. Mark Sawyer. His presentation is titled Teen Vaccines, the Challenges and Role of Providers. And Dr. Sawyer is a professor of clinical pediatrics and a pediatric infectious disease specialist at the UC San Diego School of Medicine and Rady Children's Hospital, San Diego. He is also medical director of the UC San Diego, UCSD San Diego Immunization Partnership, a contract with the San Diego County Agency for Health and Human Services, which is focused on improving immunization delivery in San Diego. Many of you know that Dr. Sawyer is very active in several groups involved in developing vaccine policy, including California Immunization Committee, which is an advisory committee to the California State Immunization Branch. He's a member of the American Academy of Pediatrics Committee on Infectious Disease, as well as the FDA Vaccines and Related Biologics Advisory Committee. He previously served on ACIP, so we've often called upon Dr. Sawyer through his CIC participation to share ACIP updates with us, and of course he was also a past president of the California Immunization Coalition. So we will turn it over to Dr. Sawyer for his presentation, and then we will close up with our questions after that. Dr. Sawyer, thanks for joining us.
Thanks very much, Julia. It's a pleasure to join this education hour. And what I'm going to cover are some of the challenges we now face to meet this new UC requirement. It always has been a challenge to get adolescents immunized, and now we have a new cohort who have new reasons to get fully up to date with their immunizations. I'm going to be emphasizing the role of providers in this exercise to get teens immunized, and then I will finish up with some very brief overview of new recommendations related to teenage vaccinations. And let me see if I can advance the slides. Nope, doesn't look like it. Prabjot, if you could please take over again and advance my slides. I have no financial disclosures related to this presentation. Next. These are my objectives for you. I hope at the end of this short presentation you're going to be able to list some of the factors that influence our success in delivering vaccines to adolescents so that you can adopt appropriate systems in your clinic to address them. I want you to be able to describe the role of a strong provider recommendation for vaccines so that you'll understand how you influence vaccine uptake. And finally, summarize the recent changes in vaccine recommendations for adolescents so that you can provide optimal care to your patients. Next slide, please. So this is one version of the immunization schedule produced by CDC. This one's actually designed for students and parents, but it's easy to visualize, so I thought I'd just quickly look at it here today. I want to focus on the green-colored bars. These are ages and vaccines for which there is a routine recommendation such that all adolescents should receive these vaccines, so that includes influenza, Tdap, HPV, and the quadrivalent meningococcal ACWY. Today we will talk about meningococcal B vaccine, but as you see there is no green bar there, and the reason for that is that ACIP has not yet issued a routine recommendation for that vaccine. The yellow-colored ages and vaccine under the various vaccines indicate catch-up times when if students have not yet been immunized, they should be brought up to date, and of course that will be particularly important for this new UC requirement for vaccinations for enrollment into classes. Next slide, please. So one of the challenges is getting adolescents immunized. It always has been a challenge. I think Dr. Buchman referred to the hepatitis B struggle that we went through in the 1990s to get adolescents immunized. The timing of this call is interesting because the CDC just last week issued the latest teen vaccine coverage rates, and I took a figure from that publication. If you want to read all of the details, it's in MMWR from last Friday. And as you can see, at the very top lines, we're doing pretty well with both Tdap and quadrivalent meningococcal vaccination, at least one dose of quadrivalent vaccine, reaching 80 to 90% coverage. But where we continue to struggle, and have for many years now, is with HPV vaccine. And for girls, we're doing a little bit better than for boys. The 3-dose coverage for HPV is now over 40%. Which shows a steady improvement. But you can see the slope of that line is going up relatively slowly, so we still have a lot of work to do. We have even more work to do for males in HPV vaccine. And then buried, the second line from the bottom there, is the second dose of meningococcal vaccine, which is a more recent recommendation. This is the vaccine dose that would normally be given at age 16, and our coverage rate for 2 doses of meningococcal vaccine is still below 40%. So there's lots of work to be done with regard to immunizing our adolescents, including those who aren't attending University of California. Next slide, please. So let me just quickly review some of the challenges that we face. First of all, it's difficult to educate the whole community about the recommended vaccines. We've had a series of new recommendations made, and we need to make sure that people are aware of that. For some vaccines, we have to educate physicians about the importance of the vaccine because we've learned that some physicians are not making strong recommendations for vaccines, and I'll go over that in the context of HPV vaccine in just a minute. Some of our vaccines need multiple doses, which is, of course, a challenge to bring adolescents back to healthcare settings to get immunized. Some adolescents don't attend clinic and physician visits regularly, so we have to capture them and sometimes think about other ways to capture them besides in the standard provider clinic arrangement. We do have a problem with some of the vaccines that we are offering to adolescents in that they are only moderately effective. So despite full immunization coverage, we will still have some problems with outbreaks of influenza and pertussis in particular. However, some protection is better than none at all, so those vaccines continue to be routinely recommended. And then there are continuing stories circulating in the community about vaccine safety concerns that are unfounded. We now have a very robust infrastructure to study the safety of vaccines through the CDC's vaccine safety data link, and every time a new question is raised about vaccine safety, it gets studied to make sure that our vaccine supply is completely safe. So we have all of these challenges to face in getting our students prepared for this new UC requirement. Next slide, please. So what makes adolescents get vaccinated? This is a paper that was just published this year, and it relates to HPV vaccine, but there are many, many other publications in both adult and pediatric vaccination papers that say the most important thing to people is their clinician recommendation. So you'll see that 36%, 37% of the respondents in this particular study said that was what made them consider getting a vaccination. Other factors are being aware of whether the vaccine is necessary. So if you look at the bottom panel on this particular table, you'll see that 16 or 17% felt that the vaccine was not needed or not necessary, and another 15% lacked knowledge about the vaccine. So we have to educate the public, and we have to have clinicians give strong recommendations in order to really increase coverage to the levels that we need to protect and prevent outbreaks of disease. Next slide, please. So this is the a slide that illustrates the problem about physician recommendations. This is also a paper from this year related to HPV vaccine. It's a survey of physicians, both pediatricians and family practitioners, listed in two separate columns for each of the categories, and it looked at their strength of their recommendation to give to their patients about HPV vaccine at 3 different age groups, 11 to 12-year-old, 13 to 15, and 16 to 18. And the rationale behind those age groups is that some providers felt that immunizing at 11 to 12 was too soon, even though that is the routine recommendation, that very few young adolescents are sexually active, so that they chose to wait to a later age group. But despite the age group, if you look up and down the columns, we have a large percent of physicians who are not giving a strong recommendation. In fact, we have some physicians giving no recommendation at all for HPV vaccine. So at 11 to 12-year-old, 10% of pediatricians and 11% of family practitioners are not recommending HPV at all. And a small percent of physicians are recommending against this vaccine, which really makes no sense at all to me. This vaccine has now been available for a number of years. It's extremely effective and extremely safe, and it prevents cancer. I mean, it seems like a no-brainer, yet we have, for a variety of reasons, physicians who have still not completely embraced this vaccine. And until they do, we're certainly not going to reach the coverage levels that we would like to with adolescent vaccinations. Next slide, please. Now, we've been studying the delivery of vaccines for many, many years, starting in the early 1990s after the nationwide measles outbreak, and we've learned a lot of things about how to give vaccines. And these are some of the tried and true systems changes that you can make in your clinic to improve coverage rate. First of all, you should immunize at every type of healthcare visit, sick visits included, as long as there's not a contraindication to vaccination that day. Children with mild illness, URIs, and that sort of thing can safely be immunized and effectively be immunized. And if you don't do it at that visit, you're missing an opportunity. And since it's difficult to get adolescents into the physician office, that may be an opportunity that never gets made up. The use of standing orders has been shown over and over again to improve vaccination coverage. By standing orders, I mean a system by which the physician does not need to specifically write an order that vaccines be given. There is a standard schedule for vaccines with intervals between doses that can be either put into a computer program, such as an immunization registry, or just there are charts and user aids that help people keep track of that information, so that when a patient comes into your clinic or office, they just automatically get immunized unless the physician finds some reason that day for a contraindication. Unlike our veterinarians and our dentists, physicians are very poor at using reminder recall systems, yet they're extremely effective. In fact, my auto mechanic sends me reminder recall notices to put oil in my car. And this has been shown in multiple studies to be effective for vaccines, and the newer methods for delivering reminder recall are quite cost-effective because both email and text reminder recall have now been studied and are very effective, particularly in an adolescent population. We need to take advantage of community immunizers. Certainly there are some communities in California that have the luxury of school-based immunization, although those are few and far between, but a very large and growing body of pharmacists and pharmacies that provide vaccinations to adolescent age group patients, and they are a very effective immunizing partner in the community, and I encourage you to consider including them in your program to get your adolescents immunized. They are about to be hooked on to the California Immunization Registry, and it's part of the law that allowed pharmacists to get immunized to require them to report their vaccines to the Immunization Registry so that that information will be available to their primary care providers. And last but not least, you should look at how you're doing yourself. When we started focusing on immunizations in the 1990s, we would visit pediatrician offices, and they would almost uniformly feel that they did a great job of immunizing and would usually quote 90% coverage rates. Yet when we audited their records, almost everyone fell far short of that. So take a look at your own vaccine delivery and monitor it over time so that you can have an accurate sense of how you're doing and put in these systems to improve your coverage rates. Next slide, please. So now I'm going to shift into the section where I talk about some of the new specific recommendations about vaccines, and then we'll finish up with questions. So this is a graph of the history of pertussis in California over the last 60 or 70 years, from a time before we had vaccination in the early 1940s to the current time, or this graph goes through 2014. And you'll clearly see on the right-hand side of that graph that we have a new and emerging problem with pertussis. I expect you all know that from your clinics and busy clinics, seeing lots of patients with pertussis. We had our first large spike in 2010, and then in 2014 even exceeded that record. And this is a phenomenon that's being repeated around the country, and it has to do with the waning of immunity from Tdap vaccination, so that DTaP and Tdap vaccination, so that within several years after vaccination, at least a subset of the people immunized are again susceptible to pertussis. So we clearly need a better pertussis vaccine, but in the meantime, we need to at least optimize the delivery of pertussis with the current vaccines that we have available. Next slide, please. And to illustrate the problem we have with adolescents, this is data from 2014, the last year where we had a very large peak. This is just from San Diego County, looking at the age groups of those affected with pertussis. These are active cases of pertussis reported to the county health department. And as you can clearly see, the bulk of the cases are occurring in the 10 to 18-year-old age group. Now, some of those patients were too young to get their booster Tdap vaccines, but many of those patients were immunized, were fully immunized. And that, again, illustrates the problem with the current acellular vaccines. You'll notice that there are very few cases reported in adults. I think that's two reasons for that. Number one, I think adult pertussis is not as well recognized as it should be. It may present just with a nagging or persisting cough. Most adults don't whoop and turn blue the way infants do. And the other reason is most of those adults were immunized when they were children with the old whole cell pertussis vaccine, which has been off the market for many, many years now, but we have learned subsequently actually provided better priming immune response than the current acellular vaccine. So people from about 20 years of age and above have better protection because of the vaccine they received way back when they were infants. But unfortunately, we don't have that situation any longer in our current adolescent population, and I think the next slide may illustrate how that is affecting our rates of pertussis in adolescents. Could I have the next slide, please? So this is a graph, again, of pertussis cases in California. This is from the Northern California Kaiser group, Nikki Klein and her group. And the red line shows the numbers of the incidence of pertussis in cases per 100,000 during the 2010 outbreak. And the blue line shows the incidence in the 2014 outbreak. And the first thing to note is between age 5 and age 10, there's a rising rate of incidence, meaning more and more children as they age between 5 and 10 are getting pertussis. And that was the first signal we had that the immunity that they developed from the DTaP they got as young children was starting to wear off. Now, I don't want you to leave this call thinking the vaccine doesn't work at all. After 1 year of vaccination, the effectiveness of the vaccine is close to 90%. That's as good as most vaccines we have. But unfortunately, the characteristics of the immune response to DTaP and to Tdap that we give to adolescents is that the immunity starts to wear off over a period of years. And if you now look at the blue line, you'll see that it too went up to age 10, and then it dropped off between age 10 and age 12 or 13. That's a reflection of adolescents getting the routine Tdap vaccine at age 11. But then, unfortunately, you'll see the curve bounces back up, and that is because of the waning immunity. So children or adolescents between 13 and, say, 18 years of age were again becoming susceptible pertussis and getting pertussis. And finally, both curves drop off at age 19 or 20. That is this phenomenon of a cohort of individuals who was immunized with whole cell vaccine when they were young, and they have better protection. So that's the situation that we're under, and the reason that Tdap vaccination is particularly important in adolescents, even though for short-lived protection, at least provides some protection at that age group. Next slide, please. So just to summarize the current Tdap recommendations, we have a routine administration at 11 years of age. We're focusing on households with newborns because newborns are particularly susceptible to pertussis, and the mortality that we see from pertussis is in newborns. And for that reason, there's a very intense effort to immunize during pregnancy now to protect infants during the first few months of life when they're too young to be immunized themselves. There is no booster recommendation for non-pregnant individuals. So although the UC system is requiring a Tdap, it is a single Tdap. Many of the students will have received that at age 11, and there is not a recommendation that they receive a second or booster dose at this point. Next slide, please. Okay, let me shift to meningococcal disease because this is a very complicated topic, the difference between the quadrivalent vaccine and meningococcal B, the newer vaccines that have just become available in the last couple of years. Next slide, please. So to summarize, there are 5 main strains of meningococcus that circulate in the United States, A, B, C, Y, and W. The quadrivalent vaccine, which we've had since 2005, covers A, C, Y, and W. And then we have the new vaccines that cover B. The primary strains that circulate are B, C, and Y, so the previous vaccine only covered 2 out of the 3 primary strains. And unfortunately, serogroup B, for which we didn't have a vaccine until recently, was most common in young children and is now becoming more common in adolescents and adults. You've heard all about the outbreaks of meningococcal B on college campuses, including our own UC Santa Barbara, and those continue to happen. And the problem with meningococcus, as you probably all know, is that it causes an overwhelming sepsis, sometimes with meningitis, and has a high mortality rate. Next slide. This just summarizes the 2 available quadrivalent vaccines for which there is a routine recommendation at 11 years of age that was first issued in 2007, and then in 2010 the second dose recommendation starting at age 16 was added on. Let's go on to the next slide. So I want to have time to talk about meningococcal B. So there are 2 vaccines available now. They're both listed here. All of the letters after the Men-B part of the name indicate the surface proteins that these vaccines are made of. And I make that point because these are fundamentally different vaccines than the quadrivalent ACWY vaccine. They're made differently. Your immune system responds differently. They are not interchangeable with the quadrivalent vaccine. And in fact, they're not interchangeable with each other as well. You have to give the same vaccine for all of the doses. The first one that became available had the brand name Trumemba. It started as a 3-dose vaccine. Just this last year, or maybe earlier this year, it was approved by FDA for a 2-dose vaccine, but not for all recipients. For high-risk people with immune system problems, it is still being used as a 3-dose vaccine. The second vaccine, Bexsero, came out in January 2015, and that has always been a 2-dose vaccine. So we have both of these vaccines available. They're recommended for high-risk patients. Those are patients with complement deficiency, asplenia, and other immune problems. And that was issued in 2015. But for the general population, we only have a so-called permissive recommendation, and I'll go into that in a minute, meaning that not every adolescent should be receiving this vaccine, and therefore it is not required by the University of California. And again, let me emphasize, these are different vaccines from each other and from the ACWY. Let's go on to the next slide. This slide sort of shows the whole problem with meningococcus and why we don't have a routine recommendation for serogroup B. This shows the incidence of meningococcus disease in the United States from the 1990s to 2013, and as you can clearly see, the rate of disease is going down steadily, and has been going down even from a time before we had any vaccine. And meningococcal B vaccine was going down along with the other serotypes, even though we've just in the last 2 years started immunizing. So when these vaccines were first developed, the rates of illness were high, and now the rates of illness are low, and we don't really know why that is. Next slide. What that translates into is there are very few cases and deaths from meningococcus in the United States, and this table illustrates it with the yellow box. In the 2008 to 2012 period, when the rates had dropped, there are, less than 100 cases and only a handful of deaths in the United States. This is the entire United States. So the question becomes, should we immunize every single adolescent to prevent a small number of cases? And that's the challenge from a public health recommendation point of view. Next slide. These are the challenges with the new meninge B vaccine. We still are learning about these vaccines. We're trying to understand the breadth of coverage. They don't cover absolutely every strain of circulating bacteria. We don't know what the duration of protection is. We don't know what their impact on nasopharyngeal carriage is, which has been important with the quadrivalent vaccine to decrease transmission from asymptomatic carriers. So we have a lot to learn about the meninge B vaccine. So the combination of a very low incidence of disease and some unknowns about the duration of protection in the vaccine led the CDC to only issue this permissive recommendation for healthy individuals and a routine recommendation for high-risk individuals, and that's where we stand at this point in time. As new information comes forward, that recommendation may change. Let's go on. So these are thoughts about who should get the vaccine. Again, there is no routine recommendation for any of these categories. These are my own personal thoughts. I think people who request the vaccine should be giving it. Some people may think living in dormitories or other crowded conditions is a risk, although in fact, that isn't supported by the data. For some reason, meninge B is no more common in college students than it is in non-college students, in contrast to the other strains. Smoking and drinking is a known risk factor for meningococcal disease, so you may have patients who practice those behaviors, and that may be a reason. But bottom line is each physician needs to make a decision with their own patient about the use of these vaccines. Let's go on so I can finish up in time and leave us some time for questions. I'm going to cut short my HPV presentation and maybe just show this one slide. So there are 3 reasons you should care about HPV. HPV causes a lot of cancer, got cut off there, but HPV prevents cancer very effectively. And lastly, we are doing a terrible job of immunizing against HPV, as I showed in our first slide. So again, these vaccines are very effective. A strong provider recommendation is important in order to get adolescents to accept these vaccines. And it's the one vaccine that we really need to work hard to improve on. Okay, Prabjot, if you could slip through the next few slides. Yeah, let's just stop here and just go back one, please. So these are the current recommendations for HPV. Routine vaccination at age 11 to 12. We now have the 9-valent HPV-9 vaccine, which covers even more serotypes and will be even more effective. It's recommended for both boys and girls in the adolescent age group, and then there are other subcategories that have older individuals who have a recommendation, and you can go to that reference for the details. And lastly, let me finish up with just a quick comment about pneumococcal vaccine with the next slide. And next. So for pneumococcus, we have two different vaccines, the old polysaccharide or Prevnar vaccine, and then the conjugate vaccine, PCV13. And the new recommendation relates to the PCV13. So let's go on to the next slide. And there are two populations now that should receive both the PCV13 and the PPSV23. And with regard to today's calls, I'm talking about high-risk adolescents who are immunocompromised from cancer or HIV infection, who lack a spleen or a functional spleen, have cochlear implants or CSF leaks, which are mechanical reasons to predispose to pneumococcal disease, and patients with nephrotic syndrome. So this is a new recommendation just in the last year or so. Your adolescents who, if they never did receive PCV13 when they were younger, should now be receiving it if they fall under those categories. The other population doesn't relate to today's call, but all adults 65 and older should now be getting both of these vaccines. Okay, last slide. So take-home points. Healthcare provider recommendations are key to getting adolescents immunized. We're not doing very well with HPV, and we could do better. Serogroup B meningococcal vaccine is available, but the recommendations for use are currently limited. Pertussis remains a big problem because of waning immunity. We need to focus on immunizing pregnant women. And finally, PCV13 now indicated for a subset of adolescents who have high-risk conditions. And one last slide, I'll end with this. I have some resources here for websites that are very informative if you need additional information about any of the specifics that I talked about here today. And I will turn this back over to Julia, and we'll go into the question and answer session.
Thank you very much, Dr. Sawyer, for that great overview. I think folks will be, in particular, pleased to have the information about meninge-B, because I think there's still lots of looming questions there, and also the recommendations for clinicians as well as those of us who aren't clinicians, things that we can do to help support clinicians in that work. So as Dr. Sawyer mentioned, we are now moving on to our Q&A period. So if you've been patiently waiting to ask a question of our presenters, now is your opportunity. If you haven't had a chance to submit your question, not on the chat, but on the Q&A. So if you have not had a chance to submit your question, please go ahead and click on the Q&A tab and type your question and address it to all participants. And Catherine Martin is going to moderate our Q&A sessions. So Catherine Martin is our Executive Director of the California Immunization Coalition, and she works in close partnership with our coalition members to convene professional and community education programs like these, media events, provider updates, and regional summit events, including our annual summit. So thank you to Catherine. I'm going to turn it over to her so she can share some of the great questions we've been receiving. And again, reminder that we are still taking questions online.
Perfect. Thank you very much, Julia. And I want to echo what you said earlier about the leadership of the UC medical directors, UC Office of the President, to thank them for this great work that they've done to address these issues that have been happening more frequently, or at least they seem to be happening more frequently on our college campuses. And this just sort of brings it together for our coalition that we want to make sure we are addressing immunizations across the lifespan. So really appreciate your great work and participation today. So we'll get right into some of these questions here. And we wound up talking a little bit about meningitis B vaccine. Two-part question here about, and I think Dr. Sawyer addressed most of that, about why the meningitis B vaccine may not be required currently at the college campuses. But another part of that question was how some practices or some of our advocates are hearing that meningitis B vaccine for those parents or students that are seeking it can be kind of hard to find in independent practices, and or at pharmacy, they're finding. So they're wondering, for those people who do want the meningitis B vaccine, is it available on campus to be vaccinated?
Most of the UC Student Health Centers do carry the meningitis B vaccine on campus.
Great.
Yeah, and correct, Mary, and I think it's available to those who request it. You know, we know there's people who are very interested in trying to get that protection, but we're certainly not pushing it on anybody, but we do want to have it in case they want to get it from us.
Great. And does that carry over for other vaccines? So let's say a student finds themselves missing one vaccine, and they want to be up to date. And they're on campus there, they can seek resources on campus for this.
Yep. Yeah.
Okay.
That is correct.
And so related, one of our questioners asked about why HPV and influenza vaccine are not required on your list.
We chose not to mandate the influenza vaccine and the HPV vaccine, primarily because we went with the California Department of Public Health's recommendation, and we were really looking at which are the ones where we've seen outbreaks on campus. HPV vaccine is not, and again, we were talking about respiratory transmittable diseases, is not transmitted that way. It is certainly an important vaccine to get for all adolescents, especially those that are sexually active, but we're not mandating that. We certainly offer it for all students that are interested in it, and we recommend it, but we're not mandating it.
Okay. Do you have a sense of how many students will be entering? I'm kind of putting you on the spot with some numbers here. Do you have a sense of how many students will be entering their records into the system? I mean, as far as how many students this impacts, basically.
Well, Mary, I don't know if you have numbers. I don't. I think we're trying to titrate this in, so rather than suddenly require it of all students, we're only requiring it of new students. So it will take us, a number of years of doing that to hopefully facilitate having a campus where most people are immunized. So, it could be, if a campus is 30,000 students, then, you're going to have roughly 7,000 or 8,000 new students per year. The campuses are all of different sizes, so it's not a small number of students. At the larger campuses, Berkeley, UCLA, Santa Cruz, San Diego, and it's a lot of work. But we are trying to do this in a phased-in way so that we can try and keep it manageable.
And we are starting to collect data on what percentage of the students for the fall of 2016 are entering their data, and we're just at the beginning process of collecting that data because for some of the campuses they haven't even started yet, and the numbers look like they varied between 40 and 75% of the students that have entered their data. So we expect that will go up as time goes on.
Right, that's a good point. This just started basically, from a required standpoint. And speaking of that, how are parents or students receiving this information? For those who may not have heard about it, are they receiving this in their registration packets? That's what some of our doctors have been asking about. How are students and parents receiving this information to be ready?
Yes, it goes when they are admitted and they have a admission checklist. It's part of their checklist on admissions. So they're getting it when they get all of their other acceptance material, and it's listed as one of their to-do things with a link to the Student Health Center's website so that they can get more detailed information.
Okay, perfect. And in that last minute or so, I was wondering if either of you could, or both, share a little bit about the impact of these outbreaks that we've had. I know years ago we had a mumps outbreak on Berkeley. We've had the measles cases at various campuses, and of course meningitis B, which, as Dr. Sawyer mentioned, is rare but can be quite devastating. I was wondering if you could share the impact on your health centers when, and the students. First of all, the students, families, and health centers when there is an outbreak.
Well, Mary, I can start. I would say at Berkeley, you know, I've been there for the past 8 years, and we've had multiple single cases, but we did have the outbreak a couple years ago, and you know, it completely subsumes everybody's activities, at least from the medical administration, who have to drop everything and try to manage, working with public health, trying to manage each new case and working with campus housing and trying to isolate people and, you know, do a contact identification process. And it is extremely difficult to manage those, and of course we worry about, you know, if enough students get sick, that someone's going to get hurt and have a bad outcome. So my standpoint is it becomes all-consuming when it happens, and you can't stop until you think things are starting to fade, and of course it may take a couple of cycles to make sure that's happening. So it's quite an investment of time and energy.
Right. Any last thoughts, Dr. Knudtson or Dr. Sawyer?
Well, this is Mark. I'll just add in that this new requirement is going to certainly help with that, because once an outbreak gets going, it just snowballs and involves not only the unimmunized students, but even some of the immunized ones who didn't respond to their vaccine. So by getting the overall protection level up high, that should minimize the chance that further outbreaks are going to happen.
Yes, a great way to end it. Thank you so much, everybody. And Julia, I'll hand it back to you.
Thank you very much, Catherine. So we've very quickly reached the end of our hour, and we want to first off thank all of our participants for spending this hour with us. We hope you found it helpful. We, of course, want to thank our presenters, Dr. Buchman, Dr. Knudtson, Dr. Sawyer, for this wonderful information. We would like to extend a thanks to the California Immunization Coalition Education Committee as well, which brings these calls to us. The co-chairs are Kathy Gustafson in WASU, and our California Immunization Coalition Project Associate Prabjot Dhaliwal was very active in planning the call and took the lead on this. We want to thank her for her time and her coordination. Please complete the evaluation, which will automatically come up on your screen after you exit this call to share your feedback. And finally, we do want to let folks know, this was a question that came up multiple times on the Q&A about the slides. You will be able to view the slides and listen to a recording of this webinar, as well as past California Immunization Coalition webinars on the California Immunization Coalition website. And this should be available within a week or so. So again, we'd like to really extend our thanks to everyone, participants, presenters, and planners, and we hope you enjoy your afternoon. And I think this will end our call, unless Catherine has anything else in closing.
No, that's it. Thank you very much, all.
Thank you.
Thank you.